Hello, very good evening. This is Dr. MJ Wesley, founder of Pacesdiaries. Today, we are going to talk about an extremely important topic, hypoglycemic unawareness. This is a topic you should know as a physician. It doesn't matter whatever exam you're going to appear for. Let it be PACES, let it be MD medicine, let it be DNB medicine, let it be FCPS. This is going to help you tremendously. Hypoglycemia is as dangerous as hyperglycemia, in fact, more dangerous than hypoglycemia. So what do you need to know about hypoglycemic unawareness? Let's start. 3, 2, 1, go. So this is the recent clinical classification of hypoglycemia. Let's see the very first classification. It's a documented symptomatic hypoglycemia. This is an event during a typical symptom of hypoglycemia accompanied by a measured glucose level of less than 70 milligram per deciliter. That is 3.9 millimole per liter. Then comes your asymptomatic hypoglycemia. It's an event not accompanied by typical symptoms of hypoglycemia, but with a measured glucose level of less than 70 milligram per deciliter. Then the third criteria is probable symptomatic hypoglycemia. What is that? An event during which typical symptoms of hypoglycemia are not accompanied by measurement of glucose level, but it resolves after action taken to reverse hypoglycemia. For example, you give some carbohydrate ingestion. Then there comes pseudo hypoglycemia. Typically, patient will start developing or feeling the symptoms of hypoglycemia. We are going to see what are those symptoms. But the measured glucose level will be normal. That is more than 70 or more than 3.9 millimole per liter. All right. Now let's go and see the levels of hypoglycemia. The level 1 is less than 70 milligram per deciliter. The level 2 is 54 milligram per deciliter. The level 3 is any hypoglycemia that needs another person's assistance. All right. So what are the causes? The most important cause, drugs like insulin or any insulin secretagogues, like your sulfonylureas. And then comes alcohol. Then critical illness like a hepatic or renal failure or cardiac failure, sepsis. All right. Then hormone deficiency. The counter-regulatory hormones like a cortisol, your growth hormone, your glucagon, your epinephrine, if they are deficient, that can lead to hypoglycemia. Then any non-islet cell tumor like mesenchymal tumor can lead to hypoglycemia. In a seemingly well individual, what can lead to? It can be due to endogenous hyperinsulinism like tumors like insulinoma, insulin autoimmune hypoglycemia, insulin secretagogues, or exercise, accidental or malicious hypoglycemia, factitious hypoglycemia, and any disorders of gluconeogenesis, prolonged fasting, even pregnancy can cause that. So what are the symptoms of hypoglycemia? The symptoms are classified into two major groups. The first bundle of symptoms is what we call as neuroglycopenic symptoms. This is due to direct deprivation of your blood glucose to your brain. Your glucose is deprived to the brain. So what happens? Patient can get confused, fatigue, seizures, loss of consciousness, cardiac arrhythmia, ultimately leading to death. Then comes your neurogenic symptoms. This can be classified into two types. Number 1 is adrenergic. Number 2 is cholinergic. The adrenergic symptoms are your tremors, anxiety, and palpitation. We call it TAP. Remember the TAP. Due to release of norepinephrine from postganglionic neurons and epinephrine from adrenal medulla. Then comes your cholinergic symptoms. They are your hunger, your sweating, your paresthesia. We call it as HSP. Remember TAP and HSP. TAP for adrenergic, cholinergic, it's HSP. Now comes the other thing you need to know about hypoglycemia is your good old Whipple's triad. What is it? First, there should be symptoms of hypoglycemia, which we have seen, and the measured glucose should be less than 50. And the glucose injection will give relief of symptoms. Typically, you will find this in insulinoma as well, and any hypoglycemia. The mnemonic is H2G. All right, why hypoglycemia is dangerous? Why we fear hypoglycemia? It's not just about neuroglycopenia and death of the neurons. It's also lead to pro-inflammatory, procoagulant, and atherothrombotic properties. These three are a dangerous triad. What happens? All this will lead to platelet aggregation. Again, decreased fibrinolysis and then increased intravascular coagulation. All this will ultimately lead to cardiovascular and cerebrovascular morbidity and mortality. And decreased nitric oxide mediated protective arterial dilatation is lost. Then comes how your body reacts to hypoglycemia. The first level, the moment your blood glucose is decreasing, the pancreas comes into action. It does two things. First, it decreases the insulin by inhibiting the beta cells, and it increases the glucagon by stimulating the alpha cells. This can lead to two things. One is gluconeogenesis, and glycogenolysis. Tackler in both your liver and your kidney. This will increase the glucose production, increase the arterial glucose. Then the brain acts in two ways. The next mechanism, this is the first. The next mechanism is increasing the sympathoadrenal outflow. What happens? You have your adrenal glands sitting on top of your kidneys. This adrenal gland has cortex and a medulla. The medullary part of the adrenal gland will increase the secretion of norepinephrine. It again increases gluconeogenesis and glycogenolysis. Also, the sympathetic postganglionic neurons, which we have, it will again increases the norepinephrine and increases the acetylcholine. Both have different roles. Norepinephrine will go ahead and act in helping decrease glucose clearance. And it helps also in increased gluconeogenic precursors like that of your lactate, amino acids, and glycerol. And then you'll be wondering, why acetylcholine? Acetylcholine is extremely important because it causes symptoms such as hunger. This hunger is a very, very important defense mechanism. It causes other cholinergic symptoms, which we have seen. Once you get hungry, you will eat, again, your blood glucose level goes up. Then the third line of defense is straight from your master gland, that is pituitary. It increases the growth hormone. Thereby, also it acts on adrenal cortex by increasing ACTH. It acts on adrenal cortex, which will increase the cortisol ultimately. Again, another counter-regulatory hormone. So now comes risk factors for hypoglycemia. Why this hypoglycemia occurs? Many times it's ill-timed or wrong-timed insulin or wrong insulin prescription can lead to that. We will have a different session on insulin prescription. Then again, it can be due to decreased exogenous glucose. And it can be due to increased insulin independent, remember, independent glucose utilization, such that exercise. Or it can be due to increased insulin sensitivity, example at night, exercise, increased weight loss, and all the diets, and decreased endogenous glucose productions. Like, for example, alcohol. Alcohol typically goes and it inhibits gluconeogenesis. Thereby, it decreases blood glucose. And then again, decreased clearance of insulin, renal failure. So, what is this hypoglycemia-associated autonomic failure? What happens? In a type 1 diabetic or type 2 diabetic, you're just pumping him with insulin. All right. So, either one of the autonomic system, nervous system is impaired. So there's not going to be any symptoms when he is going to have his blood glucose getting dropped down. For example, the patient is on beta blocker, it again inhibits the autonomic system. So what happens? Or if there is a beta cell failure, there is not going to be any increase in glucagons. And what will happen? Hypoglycemia episode will occur. And the sympathoadrenal response, which we have seen, is completely lost. As a result, there will be decreased adrenomedullary response and decreased sympathetic neural response, which will lead to defective glucose counter-regulation. And this will ultimately lead to hypoglycemic unawareness and this will go into a vicious cycle. All right. So how do you manage hypoglycemia associated autonomic failure? Intensive glucose control. First of all, it can be a boon or a boom. And you have to utilize CGM, that is continuous glucose monitoring. And you have to be very careful in adding other drugs like GLP acting drugs or GIP acting drugs. Apart from that, patient education, counseling, and Daphne, if you're practicing in UK, you should know it's a dose adjustment for normal eating. All right. So can you guess what it is? Any idea what is this mission she's having? This is a closed loop artificial pancreatic system. All right. Next, can you guess what is this? This is a dual system which pumps both insulin and glucagon. Depends on your blood glucose level. This is Daphne from UK. For type 2 diabetes, they have something called Expert Health. It helps in your insulin dosage, your weight loss counseling, behavioral change, your support group, and health and well-being coach. Thank you so much for listening. And I will see you again with another exciting video on Medicine Bites from Pacesdiaries. Thank you so much and have a wonderful day ahead. Bye-bye.